Hello everyone. So today's lecture class is on topical fluorides. So what is the specific learning objectives of this particular class is that we will be talking in detail about the professionally applied topical fluorides that are available as fluoride solutions, that is the sodium fluoride and the stannous fluoride, fluoride gels, that is the APF, and the fluoride varnishes, the Durafet and the floor protector. So now on to introduction. Fluoride is always considered as the cornerstone of caries preventive program, and the World Health Organization Committee declared that fluoride is one among the 14 trace elements that is essential for the normal development and growth of the human beings. The main source of fluoride to human body is through drinking water. So there are three levels of applications of fluoride: the community level, the group level, and the individual level. Among the community level is the water and the salt fluoridation, and among the group level is the milk and the fluoride mouth rinse, and the individual level is the topical fluoride and the fluoride dentifrices. So now on to the definition that was given by Stuckey in the year 1990. These systems contain relatively large concentrations of fluoride designed for professional application in the dental office, as well as these are the systems that can be done under the supervised home use. So topical fluoride therapy is best used as a supplement to systemic fluoride therapy and not as a substitute. So what is the reaction that occurs between the fluoride and the enamel reactions is that whenever a fluoride and an enamel come in contact, an intermediate complex calcium salt is formed, which in turn replaces the hydroxyapatite to fluorapatite crystals that will never, or it is hard or resistant again decay. So eventually these fluorapatite crystals or the fluoride from these crystals will leach away from the enamel whenever the critical pH drops below 5.5. So these are the indications of fluoride therapy for children who are in the periods of eruption, who have reduced the salivary flow, or after the placement of restorations, and also disabled children. So generally the topical fluorides is of two types, the professionally applied and the self-applied. Now we will see in detail about the operator administered fluoride therapy, where we use high fluoride concentration products, that is from 5000 to 19,000 ppm. The available products are the fluoride solution with sodium fluoride 2%, stannous fluoride 8%, fluoride gels, that is the acylated phosphate fluoride 1.23, and the fluoride varnishes, the Durafet and the floor protector. So the self-administer that we use in our day-to-day life is the fluoride dentifrices and the mouthwashes, those with low fluoride concentration in the range of 200 to 1000 ppm. So what is the procedures that to be followed by fluoride application is that we have to make sure the patient has an upright position to prevent the ingestion of fluoride. We have to make sure that the patient doesn't swallow this fluoride, and whenever a fluoride application is being done, suction is one of the important criteria. The patient should be encouraged not to eat, drink or rinse for the next 30 minutes after the treatment to maximize the fluoride uptake in the enamel. And dispensing the fluoride material into the tray is one of the important thing. We have to make sure at least 1/3 to 1/2 of the tray is full or filled with the fluoride gel. So the first one among the professionally applied to topical fluoride is sodium fluoride, that was discovered in 1941 by Bivey and Knudsen in 1942. The other name is the Knudsen's technique. So how it is prepared is that to prepare 2% of sodium fluoride, we have to dissolve 20 grams of sodium fluoride powder in 1 liter of distilled water in a plastic bottle, and if stored in glass containers, the fluoride ion tend to react with silica, reducing the availability of free active fluoride. And the concentration is 9000 ppm, the pH is 7, and the percentage of fluoride is 2% of sodium fluoride. And in case of Knudsen technique, we do application in frequent intervals at second visit, third visit and fourth visit. Usually the fourth visit procedure is recommended for 3, 7 and 11, 13 years of age, coinciding with the eruption of different groups of primary and permanent teeth. The solution after application is allowed to dry for 3 to 4 minutes. The mechanism of action is that this sodium fluoride will react with the hydroxyapatite crystal and it will form the calcium fluoride. So once there is enormous amount of calcium fluoride is formed, it will further prevent the intake or the diffusion of calcium fluoride. So this is called as the choking effect. So this fluoride will act as a reservoir, and that is the reason we give a dry time of 3 to 4 minutes. So this calcium fluoride will react with the hydroxyapatite crystals and will form the fluoridated hydroxyapatite. So which is very much resistant against the caries attack. So what does that mean is that this choking effect thus will make the tooth structure more stable, less susceptible to dissolution of acids, will interfere with the plaque metabolism and also will help in the remineralization of initially decalcified areas. So advantages is that it is chemically stable, non-irritating to gingiva, neutral pH, does not discolor the teeth, inexpensive. The only disadvantage is the patient has to make 4 visits. Next is the stannous fluoride that was discovered by Muller and co-workers in 1947. And method of preparation is that 0.8 gram of stannous fluoride is dissolved in 10 milliliter of distilled water in a plastic container. It is then shaken and the solution should be just prepared before each application, which means before each application the solution should be freshly prepared. And the concentration is 19,500 ppm. pH is 2.4 to 2.8. Percentage of fluoride for adults is 10% and for children is 8%. So ideally the technique of application is you have to clean, polish the teeth, isolate both the jaws with the cotton rolls, dry the teeth, apply the freshly prepared stannous fluoride, and you have to reapply after every 15 to 30 seconds so that the teeth is moist for about 4 minutes, and it is recommended only once a year, not like the sodium fluoride where we have to make 4 visits. Next is mechanism of action here is the stannous fluoride will react with hydroxyapatite in addition to fluoride, and this tin will also react with the stannous fluoride and it will form a new product called as the stannous trifluorophosphate, and it is considered to be the most resistant to decay than enamel. So the other end product is the tin hydroxyapatite that get dissolved in the oral fluid, and that is the one that causes the metallic taste. So advantage is that is rapid penetration of tin and it forms the tin fluorophosphate complex that is most resistant to decay. So disadvantage is the metallic taste, low pH, causes gingival irritation, produces discoloration of the teeth, etc. Next is the very renowned acylated phosphate fluoride gel that is commonly used and practiced, that was discovered by the Brudewold in the year 1963, that found out that phosphate containing fluoride would provide maximal fluoride deposition with minimal demineralization. So it is prepared by dissolving 20 gram of sodium fluoride in 1 liter of phosphoric acid. To this we are adding 50% of hydrofluoric acid and it is adjusted at the pH of 3. So comparatively, we will get a fluoride concentration of 1.23%. For the preparation of the APF gel, a gelling agent such as methyl cellulose or hydroxyethyl cellulose is added to the solution and the pH is adjusted to 4 to 5. The concentration is 12,300 ppm and the percentage of fluoride is 1.3. The same technique of application for the solution form of APF, whereas in case of a gel form, we have to make sure that once the gel is displaced into the tray, the patient is made to sit right and is asked to bite the tray. This is to substantiate the fact that the APF gel displays a high viscosity at low shear rate and low viscosity at high shear rates. The gel thins out under biting forces and more easily penetrates between the teeth. Only if the patient bites, the gel will be able to pierce or move into the, it will be easy for the gel to penetrate between the teeth. Conversely, when it is not under the stress, it remains in the tray and does not tend to run down the patient's throat. So mechanism of action here is that the APF gel is applied on hydrolysis. It leads to dehydration and shrinkage of hydroxyapatite crystals, and therefore there is a highly reactive form of dicalcium phosphate dihydrate. So the fluoride penetrates into the crystals deeply through the openings produced by this shrinkage and it will form the fluorapatite. So generally after application 30-second interval is done and the teeth is kept wet for 4 minutes. So these are the different pictures on how the APF gel is dispensed in the tray and how the patient is made to sit upright and is made to bite the tray for the proper penetration of APF gel. So this is in the form of foam. Advantage is the fluoride uptake is faster, it is cheaper and it is also has a long shell life. The only disadvantage, the pH is acidic and it has a sour taste. So this chart gives us a comparison between all the three, and it helps us to summarize between all the three fluoride therapies. That is the sodium fluoride, the stannous fluoride, and the APF topical fluoride application. So the first one has 2%, the second one has 8%, and third one has 1.23% of fluoride concentration. The ppm is 9,200, 19,500, and 1,23,000 for APF. So the frequency of application for sodium fluoride is 4 visits. For stannous fluoride is biannual. For APF fluoride is again biannual. The taste is sodium fluoride is bland, and for stannous fluoride is disagreeable. For we know it has a metallic taste, and it is acidic for APF. And when coming on to the tooth pigmentation, the only stannous fluoride causes discoloration of the tooth. Now on to the fluoride varnish. So this fluoride varnish will increase the contact between the tooth surface and the topical fluoride agents. And this fluoride component incorporated into the varnish will act as a coating material, and it will have an increased time of contact between the tooth and the fluoride uptake by the tooth. So the first one is the Durafed. That was the first commercial fluoride varnish in the year 1964, and it has a viscous yellowish material containing fluoride and sodium fluoride as an organic lacquer. It contains 2.26% of fluoride with 22,600 ppm. Its advantage is that it provides a watertight protective film insulating against the thermal and the chemical influences. Disadvantage is patient complaints. Next is the fluoroprotector. It is again a polyurethane lacquer dissolved in chloroform and difluorosilane with 0.7% fluoride and 7,000 ppm. So here the technique of application is that after the prophylaxis of the teeth, the varnish is taken in a brush, or it is taken in a single tufted brush where 0.3 to 0.5 ml of varnish is required to cover the entire dentition. So you have to start from the proximal surfaces of the upper arch. Just you have to thinly paint it over the arches and over the teeth. So the patient is made to sit with the mouth open for next 4 minutes. So here the instruction is that not to rinse or drink at all for 1 hour, not to eat any solid food for that day, take liquids and semi-solids till the next morning, and not to brush that day. Recommended semi-annual complication. So this ends my lecture where we have discussed in detail about the professionally applied topical fluoride. Thank you.